Hi, good afternoon. My name is Lydia Redden. I'm one of the nurse practitioners with the Pediatric Otolaryngology Department at MUSC in South Carolina. Today I'm going to be presenting some of our project data and results regarding the telehealth utilization in many of our pediatric trach patients that we've been discussing. I'm going to start by going over a few and then we'll talk about some of the background data and results that we have collected over the last several months. So I would like to start off by discussing a lot of the risks and realities behind caring for children that we, discharge home with a new tracheostomy and expect the families to medically manage and care for, an artificial airway and a ventilator at home, understanding that these kids are at very high risk for returning to the hospital. We also want to discuss really why do children need tracheostomies? Why is this a reality for families? And so understanding that we do need close outpatient follow-up with these families. From an airway standpoint, the ENT team manages this, so we want to make sure that we understand when telehealth might be an appropriate option for these patients. We also want to discuss the risks and the care differences with considering, their limitations in getting to and from a clinic visit that telehealth may be an option to improve. We also want to think about the education that they're receiving before they go home. That's going to impact many of their perceptions of the outpatient clinic. We're going to discuss the design of our study, the methods, where we're evaluating the telehealth use in a select group of patients. And then we're going to go over the results and some of the statistics that we found and conclude it with some of our next implications for practice moving forward. So many of our children with trach dependence, as we know, across the country, they're at high risk for poor clinical outcomes, especially after we initially discharge them home with a trach, and even greater risk when we're discharging them with ventilator and technology dependence. So caring for this child, we think about the levels of caregiver anxiety in general for patients that have complex medical conditions, but when we're adding airway management, vent management, and expecting parents to run an ICU essentially in their house, we need to think about the anxiety rates that the caregiver is taking on, as well as the outcome risk that is in the child. We also want to think about, the limitations of resources. Many of the children that we see in South Carolina are living at a pretty great distance from the hospital, at least 2-3 hours. And they are transporting these patients back and forth for outpatient visits just to tell us, trach changes are going great, but really we're having supply or equipment issues or malfunctions. What can we do to address that where maybe they didn't need to drive all the way to the hospital? We also want to think about their socioeconomic status, limited transportation, how are they getting their child to and from appointments, which if they cannot easily get to the resources that they need, there are greater risks of adverse events happening in the home. So we had some telehealth in place across the country before the coronavirus pandemic, but after the pandemic and we were forced to use this resource, we have seen a pretty rapidly evolving use of telehealth across many different specialties, and we are hoping to keep that going after the pandemic. So why do children need tracheostomy? We are really seeing a large volume right now, more from a prematurity standpoint, lung disease, bronchopulmonary dysplasia. So many of the children from the NICU needing chronic vent dependence. But we're also looking at airway abnormalities, difficult or critical airway statuses, airway stenosis, obstructive sleep apnea, just to name a few. So some of the background that is important to point out is we do have a growing number of children who undergo surgery in the country every year. So looking at numbers as great as 4,500 annually, the mortality risk of this chronic population, is thought to be as high as 42%, but when you think about just trach-associated mortality risk, we're usually looking at about 1 to 8% after a trach is placed and they are discharged home. So many medical centers have reported mortality rates to be about 13 to 25% within 1 to 10 years after trach placement. That's very high. Mortality risk is even greater when we think about those kids that do go home with a trach and they have more than 3 no-shows to follow-up clinic appointments with their specialty provider. Their risk of mortality goes up at least 25%. And so we really want to think about these outpatient visits, living longer distances, and how we can reach these patients to prevent poor outcomes. So also thinking about some of the other larger institutions across the US, we've had studies really point out the rates of adverse trach events. So when we think about what those are, that would include accidental decannulation, thinking about mucus plugging requiring an emergency trach change, maybe it's respiratory decompensation from a ventilator standpoint, and possible bleeding from the trach. So with many of these kids going home with higher rates of tracheostomy, we need to think about quality improvement initiatives across the country. So again, speaking towards caregiver anxiety, family distress that we think about that these children's caregivers are undergoing in the hospital and then following home, in addition to maybe even their postpartum process, we need to think about how to support the caregiver and the child. So for the study, we have arranged telehealth virtual visits for about 7 patients who were willing and met inclusion criteria for the 4-month time frame that we were looking at. We started with taking a lot of the patients that had just gone home from the hospital. Every patient had some frame of ventilator dependence, and every patient had also received a trach within the last 1 to 2 years. So we see many of these children in the aerodigestive clinic, which is a multidisciplinary clinic that ENT will see the patient and manage the airway, but pulmonology is also there, GI, speech, nutrition, and a respiratory therapist. So it is a great diverse clinic, but it's not monthly. When it isn't in person, how are we checking on these kids in between and contacting the provider with the caregiver? So we have an arrangement to schedule in an appointment with each family every month, check in virtually, and then if they need an in-person appointment, we're going to continue these virtual visits around the in-person appointment, reaching the children and family within their home, addressing any needs or airway concerns. So the telehealth visits, we started with the initial visit, giving a pre-test regarding satisfaction, comfort, and education since discharge, and then we repeated those surveys after the completion of 4 months of telehealth visits, where we reevaluated satisfaction and overall caregiver anxiety. This is one of the first surveys regarding satisfaction that was given. So we looked at things as voice, visual, personal, wait time, length of visit. You can see that we talked about more of the explanation and thoroughness of the actual visit with the provider. Beginning the encounters, this survey results were pretty consistent that many people were satisfied even from the beginning. There was one event that we had some clarity that was desired from an explanation standpoint and thoroughness of the clinic team and ENT provider. But by the end of the 4 video visits, we had seen a 100% satisfaction rate. The second survey that was given was the Care Transitions Measure survey. This survey we gave, again, pre and post completion of the 4 months of virtual visits. And this really addressed the education and anxiety related to the family's understanding of who to call, when to call, what is the written plan, and medical warning signs that we should address. How much comfort did they have when they left the hospital? And then we re-administered this test when they got finished with the video visits to discuss, where is your comfort now? Because many times those virtual encounters are providing continued education from a trach standpoint and addressing equipment and home needs right there in the patient's home setting. So you can see the pre and post survey responses. As we got towards the end, many of the responses had a greater rate of strongly agree, as you can see in blue. And looking at the results data, if we jump down to the caregiver anxiety preference, we see that there was a 71.5% improvement in the anxiety rates after having serial telehealth check-ins. The other two outcomes that we measured were rates of readmissions during that 4-month time frame and the clinical outcomes. So we had one participant that was readmitted twice due to acute viral illness and secondary pneumonia. That is an appropriate admission, whether that patient was seen in person versus virtually. Two of our participants had been doing great at home, but did require an emergency room visit for some isolated trach bleeding that, we scoped through the trach and had a reassuring tracheostomy and was discharged home without any event and followed up virtually with things going well, no concerns from the family or from a respiratory standpoint. Clinically, outcomes, though the short time frame was discussed, we want to make sure that we point out that there were no negative clinical outcomes identified. Clinical outcomes being additional morbidity or mortality, where we've had poor events, adverse events in the home that led to EMS response. For example, maybe downtime or a code event with a trach dislodging. We did not have any identified outcomes during this 4-month period. So in conclusion, we want to make sure that we address the readmission and emergency room events, which we just discussed, that were unavoidable, whether the follow-up was in person versus virtual. Additional limitations that we really should point out, aside from the short evaluation time frame of 4 months, we should think about the sample size, but at the time that was the willing participants plus inclusion criteria limiting us to 7 patients. We also would like to point out that there may be some family response bias in the surveys because I myself, conducting many of the virtual visits, also performed the inpatient trach education, the outpatient in-person clinic visits, and was checking in on them virtually in between. So in the future, provider diversity would be a good inclusion to consider in the next study. Also, just for reference in the discussion, more than 50% of the hospitals have adopted some version of telehealth to improve patient outcomes with closer follow-up and seeing a decrease in emergency visits since the year of 2013. So lastly, I do want to point out that many of the articles and studies reviewed for this project does enhance the thought that providers performing the telehealth encounters, really, this enables them to improve the care not only for a patient with a trach, but to meet the family where they are and use this in settings for many children with life-threatening complex conditions. So maybe not just trach vent dependence, but we should consider, all the pathways that we could progress using this to keep our patients out of the hospital. So we do recommend further evaluation to really identify a larger impact of the telehealth process on patient outcomes, including rates of readmission and caregiver anxiety. So we'd like to recommend a larger sample size, conducting this study over a larger period of time, perhaps even greater than a year, and really considering the provider diversity mentioned above. I appreciate your time today and your support. And if you have any questions, you can contact us at the Medical University of South Carolina. But hopefully we will see an improvement in outcomes and moving forward in this patient population.